Katalin, thank you so much for joining me on the Fempower Health podcast. It was so lovely to run into you at a recent local event here in Westchester County in New York. And I always love meeting people who have expertise on the pelvic health area because the more I interview all of you, the more I'm learning how little we as women know about this space, but why it's so important to be aware. So today we're going to be talking about how scoliosis impacts our pelvic health. And before we dive in, why don't you give us an introduction about yourself?
Thank you so much for having me. It's very exciting. So I'm a physical therapist. I'm originally from Hungary, and I moved 17 years ago to the States with my husband. And so I've been practicing physical therapy for over 25 years now. And very early in my career, I started focusing on scoliosis, and actually not just scoliosis, but kyphosis. So postural dysfunctions, it's a very unique area. Like not a lot of therapists do this in this country. I went for my certification, and I'm also a pelvic floor therapist. So these are my two specialties and areas: pelvic floor and scoliosis and postural dysfunction.
Those who may not know the difference between a physical therapist and a pelvic floor physical therapist, can you just tell us the difference?
A lot of therapists do general orthopedics. So the big difference with pelvic floor that we do in most cases we do an internal exam. Either I only work with females, so like vaginal or rectal exam depending on the problems, and then I determine what is the problem. Do they have tightness, weakness, or both? Then I also do what I would call more general physical therapy or postural physical therapy. Like I always assess all the muscles and all the joints. So the big difference, like I really examine the person from head to toe, like all the whole structure. So I don't just focus on one area of the body, which I think a lot of people experience when they go to PT, like, oh, my shoulder hurts. Like they're really just going to focus on that one area. So with pelvic floor, we kind of do a full body exam. And then we specifically also examine the pelvic floor and all the muscles and structures that related, like core.
Thank you for sharing that. And for those who may have not had an experience with a pelvic floor PT, I will say I've had experience, and I know many fear it because they may feel it's invasive. And I find that you all are especially trained in how to be gentle, and it's really, maybe I'm saying this right, is it's almost this exam of consent where each step of the way you're asking for consent from the patient so that they feel comfortable. So for anyone who maybe have not had this experience, I have consistently seen that, and I understand it's part of the training as well.
Absolutely. Actually, that's like the first, when somebody comes in, a lot of it is education and we talk about it. And because of my other specialty, the scoliosis, I have a lot of patients who actually come, they either have both or they come as a scoliosis or kyphosis patient. And then now, because I'm a pelvic floor therapist, I always ask them questions about their pelvic floor, and often they're surprised, like, why are you asking me those questions? So I have to explain them how it's so connected. And also because I treat for 60 minutes, I spend 60 minutes with a patient in a private room, we kind of develop that connection, so they start to feel more comfortable with me, and then they open up and ask questions. So a lot of times I actually start treating them as an orthopedic patient for posture, and then when they understand why they can do certain things, like or they keep having the pain, then I explain it to them, it could be your pelvic floor. And then they go home, they think about it. I explain, like, this is what I'm going to do. I show them the pelvic model. I show them, like, listen, these are muscles, they are inside. You can't see it, but we can palpate and feel the muscles the same way like we feel your biceps or any other muscle. And most of the time, I really didn't have anybody who said, no, I don't want to do it. So most
Hmm.
people understand and they're really excited and they're like, oh my God, like it changed my life. Like I've been to so many PTs and nobody could unlock or understand. And I love it how you look at the whole body. So it really gives me that satisfaction that my patients do get better and they see the change. Like sometimes they struggle with pain for decades before they find me. So
Wow.
it's
Yeah. And this is why I find experts like you, because I find that's such a theme, is really struggling to find answers. And this is why I love finding the really unique niche doctors because and clinicians, because where you're helping people who are struggling. So let's talk about scoliosis. And so um, obviously, from a structural perspective, it's like, okay, if we were to logically think about it, if you have scoliosis, your whole body might just be misaligned. But I'll be honest, I got scoliosis as well, and I've never really digested the possible impact on my body. And so, why don't you help us educate why it's actually really important to
okay.
understand this nuance? Because I think there's probably a lot more impact than any of us may realize. And honestly, we may not pause to even think, holy cow, I have scoliosis. Here are all these impacts. So,
Yeah.
so please educate us.
Scoliosis it's a three-dimensional diagnosis. You have a curve in the frontal plane, or you could have one curve, two curves, three curves, sometimes even four curves. Then you also have a rotation in the spine. So a lot of times the way people notice it is like they have that rib hump, or you would see like, oh, why is one side higher than the other side? Or sometimes women are like, oh, why is one breast bigger than the other? But it's really not that. It's just because your whole rib cage is rotated. And so one side is protruding or there's a prominence, and then the other side is like, looks like collapsed, and it's opposite on the two sides. You could have a pelvic shift. Actually, almost everybody has either a rotation or a lot of times pelvic shift, which will just affect your whole structure, just the way you stand, the way you walk. So obviously the body compensates, and then after a while it's like, okay, there's no more, and then that's why they start experiencing the problems, the pain, or the I don't know, pelvic floor issues, or all kinds of symptoms. And the other thing that's very important with the pelvic floor is that the diaphragm. So because it attaches to the lower ribs, and when we breathe, this muscle, right, it goes down and expands, the ribs expand. So if you can imagine that you have this like three-dimensional change in the body, like one side the muscles are shortened, on one side they're stretched out, you will have this imbalance and asymmetry with the breathing. And the pelvic and the respiratory diaphragm and the pelvic diaphragm, they work together. So when the respiratory diaphragm expands and lengthens, the pelvic diaphragm lengthens too. And then when we exhale and the diaphragm shortens, the pelvic diaphragm also shortens. So there's this imbalance with the muscles, which can cause all kinds of problems. These days, kyphosis is another big problem because we spend so much time on our phones and the computers, so the way we sit. So a lot of people have that forward head and kind of like bent over posture, which puts a lot of pressure on the diaphragm. So the diaphragm gets stuck. 99% of the patients do not know how to use their diaphragm. So
Wow.
if we understand the connection between respiratory diaphragm and pelvic diaphragm, you see why eventually it will create problems in the pelvic floor.
Let's do a quick highlight on what some of these problems are. Maybe for simplicity's sake, you can just give a list of what's
Okay.
gloom. It's more just to like help people understand
Oh,
that this, and then we can dive into, the realities of like how you can treat it and whatnot. So maybe just to
okay.
this.
I have a couple examples. I think it's easier.
Sure.
So, like, I would say the most of my patients would like would have urinary incontinence. So that's just very common because they don't use the diaphragm. When they do core work, they use abdominal pressure. Like everything, their breathing is off. The trunk pressure management is totally off because of the scoliosis and just the way their body works. So it creates extra pressure. So they're gonna have urinary incontinence. Sometimes patients come in because of, again, the pelvic shift. They have hip pain. Sometimes they even have leg pain or buttocks pain, which right away, if they go to an orthopedic doctor, oh, it's like, it's your back, it's coming from your back. But no matter what we do from the outside, it just doesn't go away. And then I do an internal exam, and what I find is tightness because, again, the body compensates. One side is stronger, the other side is weak. The glute muscles shut down. They get totally lazy, which stabilizes your pelvis, right? With walking, standing, the glutes are the most important for pelvic stabilization. And then you start compensating with the pelvic floor, and that creates tightness. So there's a muscle called the obturator, and then you have the piriformis from the outside. It kind of sandwiches the sciatic nerve. So I've seen that with a bunch of patients, like they would have like sciatic pain, but you can treat the piriformis or do all those things and it just doesn't go away. And you release the muscle, the pelvic floor muscle, and suddenly they get better. They're able to activate the muscles. We do the postural corrections and they feel great. Sometimes this tightness can radiate into the perineum. So they have issues with sexual intercourse because it's painful because of the tightness. I've had, I would say these are the most common, like the incontinence, hip pain, back pain. And then sometimes bowel problems too, a lot of GI issues, constipation. Sometimes if it's stands for a long time, it can lead to fecal incontinence too. I've had scoliosis patients when we worked on posture, everything, they were like, oh wow, oh my God, like finally I can eat, I feel normal, just because everything was so
Wow.
compressed that they were just there, nothing worked in their body. And I've had, again, these patients were scoliosis patients because for pelvic, I only treat women, but I had, for example, a boy and a man once, like groin pain, testicular pain, and I treated them and I knew it right away. I'm like, it's your pelvic floor. So I referred them to pelvic floor. But again, if they go to an orthopedic doctor, which they do, they're just like, oh, it's coming from your back. And a lot of times it's not. Like you really have to
Wow.
consider the pelvic floor. So
Okay.
so
Wow.
these would be the
Let's talk about all the potential things that can be happening. And you may listen to this episode and start to ask yourself questions to be able to frame it when you talk to your doctor, but we may not always know how to frame it. So bring this up because I recently did an episode on hypermobility and pelvic pain. And now here we're talking about scoliosis. So these are, areas that I don't think people would necessarily think to proactively mention. I'll give myself as an example. I'm kind of, I guess, maybe a really interesting patient here because I have scoliosis and not a single person has ever, 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 ever mentioned that I need to be concerned about it. It's very slight. But I also have hypermobility. So, um, yeah, so I have both. And, listening to these experts has been incredibly interesting and already insinuating that, it takes a long time for people to come to you. If they're going to an orthopedist, they may have one view. And this is, again, just how complicated our healthcare system is. We're all trained in very specific areas. You talk to us a little bit about what people should be monitoring about their body and noticing, and then maybe like a path of how to navigate this healthcare system? Because I could imagine a woman saying, let's say she's got urinary incontinence. She goes to her OBGYN. The OBGYN is probably going to, you know, go to a pelvic PT who may or may not be trained in scoliosis, and the scoliosis may never come up. You see what I'm getting at?
Yes.
So I'd love for you to kind of talk about this. I'm a woman, I'm going through these things.
Mhm.
How would I navigate this? Because I would never, ever, ever have thought to say to my OBGYN, I have scoliosis and urinary incontinence. Never would I have thought to say that.
It takes time to change the thinking of people, and I do feel like the medical system, it's like everybody's very specialized, so you have to find the right providers who will look at you as a whole and not just the body part. One, you have to be your own advocate and think about your own body, because you're the only one who understands and really knows what's going on. And just because somebody says no, it's not that, like, but you know something else is going on, you just have to go and go until you find the right person who can actually figure out
Yep.
what's going on and
Okay.
why you're experiencing all those symptoms.
Okay. So I know that, so one would be, hopefully people know that they may have scoliosis. And so from this episode, they're kind of getting a sense of things that can happen if they do have it. We may come at it from the side of people having some of these symptoms that you discussed, like the GI symptoms, um, incontinence. Is prolapse also, could that be
Well,
impacted
yes, I didn't talk
by
about prolapse, of
scoliosis
course.
or not so much?
Absolutely. Actually, yes,
Okay.
prolapse is a big one. So, um,
Okay.
because of the trunk pressure management, a lot of people do have prolapse, especially if they also had babies. Although I have to say, not everybody, like, you don't have to have babies to have prolapse. So if you have that trunk
Yep.
pressure management and like constantly pushing down, and putting pressure on the pelvic floor, yes, absolutely. And again, what I also mentioned with the kyphosis patients, like they really grip and pull in at the diaphragm level. So I always explain it to them, just think about it as like a toothpaste when you're pushing the toothpaste out. Like if you press in the middle, the pressure is going to go down. So that's exactly what happens when you're not using your diaphragm. Like that pressure is going to push down and push all your organs, forcing them down. So that will create the prolapse and all the other symptoms. So when I teach them the pelvic floor contraction and core contraction, I always explain, it's like, think about like you're pushing out a toothpaste. You have to push it out from the bottom, right? Otherwise, it's just not going to work. So,
Okay.
absolutely.
So, okay. So then I guess when when something like this is getting treated, I guess I'm just thinking about this patient who may be going to all of these different clinicians and struggling with these different aspects, but what I'm hearing is it really is about this root cause. And so what I'm almost sensing is the pelvic floor is almost the center of it all. And almost everything else radiates from there. So if our body isn't set up to optimize our pelvic floor, so if you have, I guess, scoliosis, hypermobility, et cetera, and part of why I don't know if these examples help, and is like for me in training for this marathon, because I'm running so much, my body's really getting beat up, and my left side, I always have an issue. But in going to the doctor, it's interesting how it's being treated because, for example, on my foot, we noticed that I'm twisting it out more. I'm supinating, over supinating. And so we've been
On
fixing
the
for that on my
mhm.
left foot, right? But we haven't
Okay.
gone to pelvic floor scoliosis. But to me, that's the root. But yet I'm going to the doctor and getting that sorted out. But it's really
Yeah.
interesting how we approach the healthcare system, and but like really still trying to address the root cause. So I'd love to get your thoughts on this because
Yeah. I mean, I guess because I do so much like scoliosis and postural, like I will tell you, I always start with breathing. So I always start with the diaphragm. I always release the diaphragm. I always teach the diaphragm. A lot of times, the first session, that's all I give patients, and they come back the next session, whether they have weakness, tightness, um, and they are like, oh my God, I feel better. Like sometimes much better, sometimes a little bit better, just because they create that natural movement in the body. So the pelvic floor starts working better, everything just loosens up. So the breathing also has a calming effect on the body, right? So the mindfulness and the body mind connection here is super important. We have so much stress in our lives. So just the breathing itself. So I always teach them that. And I have so many people, they're stressed out, anxious. I always ask about that. I also have some mental health training in my background. So, and it's actually kind of sad because I would say 75%, a big, I don't know, I don't have the exact numbers, but a huge portion of the people, kids, adults, have so much anxiety and stress. So just yesterday I had a kid and she was like, I'm so anxious and stressed. And then actually she told me, she's like, can we do some breathing? And I'm like, yeah, of course. So we do some diaphragm breathing, rotational breathing with scoliosis. And then the visual I like to use for them is, or what I like, imagine your head is a snow globe. And this snow globe is like shaken up. Your thoughts are just going. You can't calm down. You can't relax. And just as you breathe in and out, just think about the snow globe kind of slowing down and all the particles resting and relaxing. And people just, everybody just loves that. And this kid yesterday, she was like, at the end, she was hugging me and so happy. You have to learn to, okay, how do I, again, pressure management, which pelvic floor and breathing are just together. You cannot separate the two. So I always look at how people, like, do people hold their breath? How do you do the core? The core is actually very, very important. Almost, again, 90% of the people, when they do core, they do the exact opposite. They hold their breath and want to inhale when they tighten. So they do the opposite, what would be like the functional way of doing it. So you're supposed to tighten when you exhale because that's when the muscles shorten. But most people want to do it exactly the opposite, and they kind of argue with me. It's like, no, I I can't do it that way. I want to do it the other way. So I have to, or I find it, that's another very interesting thing. So I've had this happen to multiple women when I'm like, okay, uh, let's see what happens when you tighten and when you do core. So I ask them, okay, tighten, bear down, and they do the exact opposite. I'm like, you're bearing down when I'm asking them to tighten. They're like, no. So they actually argue with me. I'm like, no, I'm tightening. I'm like, no, you're not. I'm like, I can feel it. And then I ask them, I'm like, okay, show me how you do the core. And then I see their belly protruding, coming out, and like they're pushing down. So it sometimes takes a lot of convincing to so they believe me. I'm like, you're doing the opposite what you need. So we have to work from the feet up, and the feet through the fascia, everything is connected. I teach you all the pieces, and then we put the pieces back together so the body can work then in harmony together and correctly, right? So that's how I treat. It's like peeling the onion.
What you haven't said, and so what I'm gathering is you don't necessarily need to fix the scoliosis, correct? Because you
Have
start.
mentioned hypermobility a few times. So if I have a patient who has hypermobility, there are pros and cons. So you can do better corrections because you have more movement in the spine, but you have less stability. So with you probably I would need to work on more stability. And when you have hypermobility, certain muscles will be tight because it's trying to hold things together. So you might feel like, oh, like I need to stretch my hamstring because it feels good, but you may not need that. So, like, I would probably tell you, like, okay, maybe roll it or do other things, but you're already so stretched and hypermobile. You don't need to stretch more. You need to stabilize it. If I have somebody who's very stiff, they will not be able to do a lot of corrections because they just don't move. So
Right.
then maybe I have to do a little more manual work on them, stretching, loosening things up so everything kind of frees up. So with kids, you can do a lot of corrections.
I bet.
With adults, I always tell them the goal is not to fix your scoliosis, even with kids. Like we want to slow down the progression. We want to make them stronger. But with kids, you can decrease the curvature sometimes, but not always. But with adults, it's really just to give them a different stability. So the way I always say is just imagine you're always doing everything in your curve. So when you sit, I look at you. So let's say, I don't know, you have a curve. And again, it depends on the curve. But let's say you always sit on your left side because the curve pulls you to the left. Then I teach you how to put equal weight on both sit bones and just sit up a little bit straighter. When you're standing, I point out, like, do you see how you're standing? So we do the easy positions, and then we go more functional, like moving arms, moving legs, doing squats, because we have to bend, we have to pick up things. So I start doing more functional, or somebody who is, I don't know, I always, if they do certain exercises, or you're a runner, so I would work with the exercises that you want to do. And core is actually also a very interesting thing. So, I mean, I also teach them what not to do. So crunches, right? When we bend forward, that increases the curvature. So you don't want to do it. So we want more neutral spine. So what's interesting with the core is when you have scoliosis, there's always rotation in the spine. So when you do um, like a marching. So you're lying on your back, and I ask you to engage, lift one leg, right? And keep your pelvis stable. There's always rotation. So one side of the pelvis drops. And so you're always strengthening into your curve, right? So sometimes I use passive corrections, or I just teach the person's like, okay, stabilize and make sure your pelvis does not pull you into your curve. So it's a lot of mental work for them. And then, of course, because we were talking about pelvic floor, right? Like, let's say you had weak pelvic floor, then I would also first teach you to engage through the pelvic floor. So I kind of monitor it to make sure you're not pressing down, and also do the nice diaphragm breathing and engage through the pelvic floor. And then once you can do that, then we go into the harder exercises and the more functional exercises. So because when you run, you can run in your corrections, right? But you train your muscles to activate better, um, and more balance. So when you're walking, when you're running, you're in a better position. So that's
Okay.
the goal of the treatment, right? So
Okay.
you're not stressing not over stressing one structure, and your all the muscles are active, like, and working, like your pelvic floor is active, your core is active, your glutes are active. So because we sit so much, the glutes shut down, then maybe the pelvic floor muscles take over, and then you have tightness because of that. But I always say, if I have a tight bicep, it doesn't mean it's strong, it's actually weak. So if I put like a bag and I was like, okay, hold it, you wouldn't be able to hold it. So the same thing happens with the pelvic floor. So like
Okay.
you're running, and then and the pelvic floor cannot hold anymore. So you could have
Okay.
that tightness, like, right, you're not using your diaphragm, things are not working correctly, then you may become, you may lose urine or even bowel movement. So
Interesting.
because the muscles are just not working correctly. So actually with marathon runners, it's a big work because it's so intense and so much stress on the body that you really have to make sure everything works together. And I always make this joke. I'm like, just imagine you have a household with 5 people in it. Like, if only the mom does all the jobs, then it's not fair, right? Everybody has to pitch in so we can all do it together. The body is the same. It's not fair if one structure, only the pelvic floor, only one side of the hip, or it all has to work together. and
Yep.
and that's like the job I do. I kind of pick and watch and see, okay, what's working, what's not working, what needs relaxing, what needs more tightening. So,
Yep.
and then you kind of put the pieces together.
That makes sense. One question I had as you were talking about some of these exercises, I think back to um, so my son is in occupational therapy, and I learned something, and which is an unbelievable field. Like, wow, I want to go. It's absolutely fascinating. So one of the things that she was saying, because I didn't really appreciate all that he needed support with. And she said to me, whenever a kid finds something hard to do or they don't want to do it because it's hard, that's usually an area to focus on. So, like for the kid example, I'll say, like, he didn't like writing. And
Hmm.
he would always eat with his hands and didn't want to use forks and knives and things like that. And so they've been working a lot on that because it wasn't that he was lazy, it's that those things were very uncomfortable. So as I'm hearing you talking, like, I'm assuming that a lot of these patients, like there's certain exercises that are just pure torture. And that could possibly be a sign, and not torture necessarily painful, but just like least
No, I
favorite,
know.
right?
Yeah.
Um, and maybe those are also hints of what could be going on. Would that be a fair assessment?
Yes. I mean, um, absolutely. It's uncomfortable. Like, actually, the way I explain it to my patients, because I get very excited when they do a good correction and they're doing exercises right. And I always explain it to them like, I know it feels to you. So somebody who doesn't have scoliosis, I always say like, okay, create a curve and not do everything like that. And I could be telling you, like, not you're straight, you look great. Okay, stay like that. And they would be like, okay, you're crazy, lady. I cannot do this. That's how it feels for somebody who has a postural dysfunction, kyphosis or scoliosis. When they are straight, their brain is telling them, like, no, 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 this is not okay. Like, this is not straight. Like, I can't. So it's very, very hard, and they're going to fight it. So, and so I do, especially with kids, I try to distract them. So I talk to them. I'm like, tell me what you had for lunch, or I make them count backwards, and then they lose the correction. They do nothing. And I'm like, I'm still watching you. You have to maintain your corrections. And then it's just so interesting. You distract them a little bit, but with adults too. So I talk to my patients a lot, and then I watch them. And then, I mean, if you've been coming to me, you know my tricks, but I'm always like, you still have to be in your, like, try, because in our daily life, we multitask. We don't just do corrections. And the other thing, it's like rewriting the program in your brain, your neuromuscular system. Um, like, you have to learn a new pattern. So getting rid of these maladaptive patterns takes a long time. It can
Yep.
take 6 to 12 months. So people have to be patient. So again, depending on the diagnosis and what's going on. I mean, I've had patients who like pelvic floor who got better after a few treatment, but then if we add the postural component to it, it definitely takes longer and a lot of practice and the being consistent with it, because it's better to do 10 minutes every day than do 1 hour or 2 hours on Saturdays.
Yeah.
Because you have to get rid of these patterns, and it's really hard to get rid of the patterns. We don't even realize that we are doing it. So it's a lot of it, and it's painful because it's, you know, crossing your leg. That's really not good for you because you're twisting, and it's not good for your pelvic floor or the way you sit. Maybe you have tightness, maybe you have tailbone pain. Like I had that too with patients. And then the way you sit, so you have to figure it out. Like I always tell people, like, do little post-it notes or set an alarm so you remind yourself, like, okay, like reset, and eventually it will work, but it's painful. Like what
Yeah.
you said, in a way, it's hard. It's
Yeah.
mentally exhausting to do it.
Right. But it's worth it because what I'm almost hearing is, there are these really frustrating and sometimes really bad things that can happen if we aren't proactive and if scoliosis is a contributor to pelvic floor issues. Someone were to be formally diagnosed with scoliosis and they knew that, would you say that it's probably important to start learning how to correct it so that in the long term we don't have these
So
issues?
so I always say it's always worth it to take a look. The way I see it is like the body compensates, then it gets to that point, the last drop, and then you're going to have symptoms. So it's
Yep.
the body always reaches somewhere. So it happens like with kyphosis. So first, like you have the forward head, then you start bending your knees, your hips, and there comes a point where you cannot be straight anymore. So it's the same with this. I know if you do nothing about it, most likely later in life, it will create problems because your diaphragm is stuck. You're not
Okay.
using it. And women, we tend to be holding. I don't know if it's like we just want to be skinny, or I don't know what it is, but women always hold. They're like, they ask me like, oh, should I always hold my core tight? I'm like, no, just breathe. And I always tell them, like, just trust me, just because you breathe and your belly comes in and out, I promise you're not going to have a bigger belly. It's actually going to be like less. But I don't know. I noticed that with women a lot, they hold, and, um, and again, that will eventually affect their pelvic floor. The other thing I didn't talk about, like scar tissue, right? Like a lot of people have C-sections or maybe hip surgeries. So the scar tissue again creates adhesions, less movement that can affect something in your body. So again, this is a personal experience. I had three C-sections, and I had back pain now for a long time. And I know my core is strong because I know how to do core. And it wasn't until one of my colleagues worked on my scar. And after like 2 times, my back pain went away
Wow.
because I had so much adhesion
Okay.
that it was pulling on my tailbone. So it just crazy how everything affects
Yeah.
everything. So,
No, it really
and
does.
then and with like hip surgeries too, so that's another one. With hip problems, a lot of time I see pelvic floor tension a lot
Okay.
of times because the
Okay.
muscles will compensate.
Yeah, it's I guess the summary that I'm hearing and talking to you and so many of these experts is like really anytime, obviously scoliosis, hypermobility, all of these things that I've been interviewing on, but it's also in this last point, like anytime the area between maybe your belly button or your lower ribs to your mid thigh, if anything's getting affected there for any reason, childbirth, I'm sure like a hysterectomy, all of these things. Like I have
Oh
a
yeah.
an expert I interviewed, her entire practice is hysterectomies and pelvic PT. That's her entire practice.
Yes.
And so it really is like, here's yet another example of like, I don't know. I just feel like the pelvic floor is a bigger deal than I think any of us have ever imagined. And it's just really fascinating to talk to you all and to just
Absolutely.
realize how important it is to get it stable, because there
Yes.
are long-term impacts if we don't. But if we know we have these issues, just go visit a pelvic PT and just at least get an exam to have an idea of what's going on is kind of what I'm taking away from this.
Exactly. It's kind of like because we don't see it and it's an intimate part of us, I think we tend to ignore it and people are embarrassed about it. So we have to get over that. Like, no, it's muscles and you have to treat it the same way as you treat any other muscle. And because I always say, like, when I teach posture too, it's like I call the pelvis is like as the base of our house. So the pelvic floor is that support on the bottom. So yes, if something is off, then the pelvic floor is going to be the first structure that gets affected. So and women, we really have to step up and talk about it and not be embarrassed about it, because you can treat these problems. And when you have, yes, a hysterectomy or any surgery, I mean, I've had patients who had sling surgery for prolapse and they still had problems and nobody told them to go to pelvic floor PT. So I just had another success story with that. Like, the patient is literally almost crying in my office because her life changed just because we were doing pelvic floor PT, and she has zero symptoms and she's finally back doing everything she
Wow.
likes to do. So we have to, like, basically just educate, talk about it, and not feel embarrassed about it. It's part of our body, and
Yep.
it's
Yeah,
it's very it's very important.
absolutely. Yeah, my conclusion from this is we need to have a primary care doctor, an OBGYN, and at each life stage, visit a pelvic PT. Like, seriously, right?
Yes.
I mean, that's the conclusion. So hopefully our healthcare system will start reimbursing clinicians for that and make
I,
pelvic PT part of proactive care. I mean, it is just an unbelievable specialty. So
yeah.
yeah,
And like the education also has to change. Like, I mean, I'm sure you've heard it from other providers. And I know menopause and perimenopause is a hot topic now, like how uh, doctors, OBGYNs, they're just not trained. So
yep,
they don't even know. They're like, well, it's menopause.
yep,
And so they really don't guide you. Nobody really prepares you. So it's definitely, there is a big gap. And I mean, I'm hopeful because I feel like women are more proactive, and I do see the change, but it has to be, yes, like insurance, it has to be covered by insurance. It
yep.
has to be something that's just offered to every woman. So without any question.
Yeah, no, exactly. Exactly. Well, this has been wonderful, and I really, really, really appreciate you making time to educate us on this topic. It is something that was new to me, and I think it's going to be helpful to so many people and people that speak it anymore. But anyways, thank you so much, Katalin. It was so wonderful to speak with you about this topic, and I know this will be helpful to so many.
Yes, thank you so much. This was a pleasure for me too.